Next few minutes, I'm going to talk to you about the role of surgery in metastatic renal cell carcinoma. Patients who had metastatic renal cell carcinoma obviously have a systemic disease, so usually treated with a systemic therapy. However, there is some role actually in surgery for treatment of these patients. Some of the patients even have a variable natural history. Not all of them, they are behaving the same. But most of patients with metastatic renal cell carcinoma will require treatment, and surgery is sometimes part of this therapeutic plan. What is the role of surgery? Surgery have an important role, but it's actually variable. It can come as a nephrectomy, and this is maybe performed as a combined modality approach in order to decrease the bulk of the tumor prior to systemic therapy. We call it cytoreductive nephrectomy or debulking nephrectomy. But also surgery have another role, which is not maybe applicable in other cancers, metastatectomy. And this is performed typically for patients who have very limited number of metastases. Typically, they have maybe single metastasis. Or the other intervention with surgery is a palliative nephrectomy for those patients who have a lot of symptoms, and we need to control the symptoms because of the local tumor effect. Nephrectomy, sometimes referred as a cytoreductive or debulking nephrectomy, may be performed prior to systemic therapy, and it is a reasonable treatment option for carefully selected patients. Although regression of metastatic disease has been described following removal of the primary tumor, but this is actually very rare. Some patients, we do nephrectomy, and after 3 months, we get really a very surprising results. Everything disappear, all the metastases. And this is actually, unfortunately, is rare, but we're not doing the surgery for this. But the basis of doing the surgery come actually the era of immunotherapy with 2 well-known trials. The SWOG trial, which they basically randomized patients to receive interferon alone or interferon preceded with a cytoreductive nephrectomy. And they found that actually the overall survival was in favor of those patients who had a cytoreductive nephrectomy. It's also been noticed, which is actually important in the to be applied maybe in the future, that those patients who have a good performance status, they benefit the most out of it. The other trial, which is the ARTC trial, they have the same thing, and they basically randomize patients to have immunotherapy with cytoreductive nephrectomy versus immunotherapy alone. And they found also that they have a survival benefit and also time to progression benefit for those patients who had cytoreductive nephrectomy. So the question is, can we extend these results to the patients who are receiving a molecular targeted therapy or immune checkpoint inhibitors? It seems to be reasonable to do this, but unfortunately, till now, we don't have the randomized trials which can answer the question. However, the non-randomized studies suggest that there may be a benefit to nephrectomy in these patients as well. An example of these studies that showed International Metastatic Database Consortium, comparing 201 patients who underwent cytoreductive nephrectomy compared retrospectively to those patients who did not. And they found also that there is improved overall survival in favor of those patients who receive cytoreductive nephrectomy. However, they also noticed that there are some poor risk features. Those patients who have the poor risk features, they have a marginal benefit from the surgery, which indicates the importance of patient selection. So the patient selection, it requires a multidisciplinary approach and reviewing of all the patients, discussing all the patient prognosis and the performance status, radiological features of the primary metastatic sites, what kind of systemic therapy that the patient have, how is he well enough to accept and to be fit for all this intervention. So that's what we do actually in our tumor board. We discuss those cases among our colleagues and to find out which patient is the best that he can benefit from this combined approach. There is no universal approach for selection of appropriate patient with metastatic renal cell carcinoma who should have a nephrectomy, but in general, selection of patients should be done with considerable care of that appropriate patient can be proceeded with systemic therapy. So if the patient is not a candidate for systemic therapy, there's no point to do a cytoreductive nephrectomy. In one of the historical series, they are using some criteria which make them enabled to select more than 90% of patients to go with immuno-based therapy. This criteria is, one of them is greater than 75% of tumor debulking possibility, performance status of ECOG 0 or 1, adequate organ function, and no evidence of extensive liver or bone metastasis. So if we are, like, this is what I'm saying, that if we review the patient and we found that we'll be able to do more than 75% of debulking of the tumor, he has a good performance status, adequate organ function, so that maybe is a good candidate to go for cytoreductive nephrectomy. And this actually graph showing those patients who have good performance status, they have actually better survival. Also in the study of IMDC, which basically found that the patient with estimated overall survival less than 12 months, and they have one of these criteria like anemia, thrombocytosis, neutropenia, poor performance status, and less than 1 year from the diagnosis to treatment, these patients they're doing poorly and they don't really benefit from surgical intervention. Role of retroperitoneal lymph node dissection, and this is actually controversial among the uro-oncologists in case of renal cancer with a lymph node, but in case of a metastatic disease, is actually at least one report suggests that there is no advantage of this approach. Other data suggest that the presence of retroperitoneal lymph nodes is actually a poor predictor for prognosis. Given the activity of molecularly targeted agents like VEGF and immunocheckpoint inhibitors, the question comes as why not we give it before the surgery? And so we have to test it before the surgery, and then we test it after the surgery, and probably we'll find out which one is better. So there are only limited data to inform the role of nephrectomy in these patients. And in the absence of these results, prospective clinical trials, in the absence of the prospective clinical trials, we have to get whatever data we have from the retrospective studies. Retrospective data supports the role of cytoreductive nephrectomy in carefully selected patients with metastatic renal cell. And one study included almost 1,700 patients from the IMDC. All of the patients were treated with VEGF or mTOR inhibitors. They're comparing those patients who did have cytoreductive nephrectomy compared to those who did not. And they found also that they have a survival benefit. While the evidence of the patient selection bias for those undergoing surgery, like for example, they were significantly less likely to have non-clear cell pathology, bone metastasis, and liver mets, and you can understand that this is inherited bias and features of the retrospective studies. But if you adjust for all of these four prognostic risk factors, still surgery have a favorable effect and survival. Role of cytoreductive in the area and the era of molecularly targeted agent. For further analysis, the suggested patients likely not to benefit from surgery include those who have more than four risk factors, the one I mentioned before. You have anemia, thrombocytosis, poor performance status, and the expected survival less than 12 months. Usually this patient doesn't really benefit from that. Another study, large study, using a sample of the National Cancer Database, identified patients with metastatic renal cell treated with targeted agents between 2006 and 2013. And they get actually a very large number. We're talking about more than 15,000 patients. Almost a third of them, they underwent cytoreductive nephrectomy. But they found that in their analysis that patients tends to be younger, tends to have a privately insured or treated for academic center, and had lower tumor stage as well. So these patients are more likely to go for cytoreductive nephrectomy. And the overall survival was significantly longer in patients managed with cytoreductive nephrectomy compared to those who did not. While these data are provocative, but they are not completely sufficient to inform about the benefit of nephrectomy, because we always need clinical trials. So we have two prospective randomized clinical trials. We have the Carmina trial and we have the short-time trial. Carmina trial is basically comparing between patients who have cytoreductive nephrectomy followed by sunitinib versus sunitinib alone. And short-time is actually testing both, testing to give the targeted therapy prior to nephrectomy compared to those patients who get it after the nephrectomy. Early report showing for the third time actually, which have a problem for poor recurrence of the patients. They only get only 99 patients, but the interim report analysis doesn't show a difference between patients who get sunitinib prior to nephrectomy versus those who get it after. Again, the problem is the low number of recruitment. For the Carmina trial, it's actually, they did not actually have it completed yet. They are going maybe to get the report at 2020, which is actually, still we have time for that. If we go to metastatectomy, this is another different surgical approach in renal cell carcinoma. Metastatectomy, it's different. You can get metastatectomy where the patient presents with renal cell carcinoma, so it can be combined with a nephrectomy, or it can be metastatectomy in later stage. So you will do a nephrectomy, then the patient develop metastasis, will do metastatectomy at that time. Or those patients who have not responding to systemic therapy. So we can have metastatectomy in one of these clinical conditions. In selected patients with metastatic renal cell carcinoma, surgical resection of metastases can yield long-term survival as compared to the other disease. An example of this is a study showing that with a recurrent renal cell carcinoma, almost 50% of the patients, they have removal, complete removal of the metastases. Another 25% have a partial removal, and another 25% have no removal. So those patients who have complete removal of metastasis have the highest survival. This is, we're talking about actually 5-year overall survival, and we get 44% after resection, complete resection of metastasis as compared to partial or no resection. So survival rate after complete resection of a second and third metastasis also were not different from those who had initial metastatectomy. What is the predictor of prolonged survival? The disease-free interval from nephrectomy till detection of metastasis is one of the most important prognostic factors. So those patients who have developed metastasis after 1 year from the nephrectomy, they get 55% cancer-free survival as compared to 9% for those who develop the metastasis less than 1 year. Single site also is favorable as compared to the multiple site, and you can see here is a 54% versus 29% of 5-year cancer-specific survival. Especially it is favorable if we have only lung metastasis as compared to the other site of metastasis. Performance status, it plays a very important role. Those who have a good performance status, actually they show a better survival as compared to those they don't. Another one is the absence of prior cytotoxic chemotherapy. So when we say carefully selected patient, what do we mean by this? We mean this. All these factors, time between nephrectomy to metastasis, more than 1 year, very good performance status, absence of prior cytotoxic chemotherapy, and also the lab parameters that I mentioned before of thrombocytosis, anemia, etc. Lung metastasis surgical resection following surgical resection of lung metastasis in carefully selected patients has been associated with 20 to 50% 5-year cancer-specific survival, and complete resection of lung-only metastasis associated with markedly improved survival as compared with incomplete resection, talking about 7 to 73% for those who have a lung mets. So these are actually very good results for metastatectomy in renal cancer. However, unfortunately, it's been applied to lung mets, but probably is not applied as well to the other mets. For example, liver metastasis, it has actually negative impact on survival, and the resection of solitary metachronous liver metastases are possible, although the morbidity is high. And also the report suggests that with the careful patient selection, 2-year survival is greater than 50%. And you can compare this one to the lung, which is actually much more favorable. What are the factors that identify who is the most appropriate patient for hepatic metastatectomy? Are those actually that been gone for curative intent, so a complete resection? The interval is more than 24 months from the renal cell carcinoma diagnosis to the development of liver metastasis. You can notice when we talk about lung metastasis, 12 months. Here is a little bit longer. And tumor size less than 5 centimeters, and feasibility of hepatectomy that based on the size and location of the metastasis. Bone metastasis, excision of bone metastasis may be considered in carefully selected patients, particularly those who are symptomatic. In one series of 295 consecutive patients with metastatic renal cell carcinoma who had a solitary lesion, intractable pain, or impending fracture underwent resection, the overall survival was for 1 year and 5 years. It is actually 47 and 11%. So you can notice that the survival benefit is not that great when it comes to bone or liver mets, but it's as compared to the lung mets. The best also, as I would like to maybe mention it later on, what are the factors for the bone metastasis. Brain metastasis as well, it can be also surgically treated, and it depends on the performance status and also the time from the diagnosis, and also the number of brain metastases. Residual disease after systemic therapy. Some patients with widespread metastasis, they received systemic therapy and they get a good response. However, there is a residual disease. Do these patients benefit from surgery or not? So resection of metastatic disease appear to be effective following systemic therapy in carefully selected patients. And this came actually from the data that being applied in the era of immunotherapy in the interleukin and interferon. There was a series of 31 selected patients with renal cell carcinoma who had a partial or complete response, then underwent resection of relapsing residual disease. The 2-year progression-free survival was 37%. Some of them, they have actually very durable response, even staying for several years. Pathology of this resected lesion after systemic therapy reveals usually active lymphoid infiltrate surrounded with residual tumor. And sometimes there is no evidence of residual tumor. Data of the patient treated initially with targeted therapy are more limited and shorter duration, but also support the role of metastatectomy in appropriately selected patients. Local recurrence, although the majority of patients who develop local soft tissue recurrence, they die from metastatic disease, there is limited data to suggest the resection of recurrence may prolong survival in a carefully selected patients. So who do better in for these patients? Those who have a longer time to recurrence following nephrectomy, and those who have small volume recurrence disease. This is the cases that we see patients who have radical nephrectomy, and then several years later they develop local recurrence. And then they have a discussion with our colleagues, medical oncologists, what to do with this one. We go with therapy or go with the resection. It seems to be that if the local recurrence is small, and if the time between nephrectomy and appearance of the soft tissue local recurrence is long, then probably surgery play a good role here. So in conclusion, we don't have a high-level quality data in terms of prospective randomized studies that address all of the issues that we present. However, the available data support that well-selected patient can have a durable disease-free survival. So what are the highly selected patients? Is those who have favorable factors that reflected by the histology, by good performance status, the lab parameters that we showed earlier in terms of anemia, thrombocytosis, the involvement of metastasis to lung only, and also those patients who have a metastasis, they have fewer sites as compared to multiple, longer interval from nephrectomy to metastasis. It seems to be playing an important role. Role of pre and post metastatectomy within the systemic therapy is not clear yet because it's not been addressed clearly with clinical trials that we are really in need for them to address all of these issues. Thank you very much.